Very good. Let's go ahead and get started. Good afternoon to everyone. Welcome to today's session where we will be sharing the results of the Canadian Myasthenia Gravis Journey Mapping Initiative. My name is Samara Osman. I'm the VP of Research and Public Policy. And on behalf of MDC, we're really grateful to have you all here today, especially as it is June, which is Myasthenia Gravis Awareness Month. I'm joined today by my colleagues, Victoria and Zainab, who I'll be turning it over to set the stage. What is MG? What is myasthenia gravis? What is our current understanding of the state of disease and treatment? And then we'll jump right in excitedly into the results. Over to you, Zainab.
Thanks, Amira. So like Amira mentioned, before we dive into the results from the Journey Mapping Initiative, it is kind of important to take a step back and learn about MG overall, because there might be people on our call that may not be familiar with myasthenia gravis overall. So myasthenia gravis is a neuromuscular disorder, and it literally translates to serious muscle weakness, which is often a symptom that people with MG will encounter. But it's interesting in that it is also an autoimmune disease, and autoimmune meaning that instead of our immune system protecting itself, it begins to attack itself. And myasthenia gravis is considered a rare neuromuscular disorder, and our best estimate is that there are about 10,000 Canadians experiencing MG. And what you'll hear today is that there are often a lot of misdiagnoses around MG and during the MG journey, and this might be causing this number to be a lot lower than what it is. Next slide, please. So as I mentioned, myasthenia gravis is an autoimmune neuromuscular disorder. But we need to understand what's really happening in our bodies on a larger scale. And so our bodies create antibodies to help fight off infections and disease. And our nerves conduct signals to our muscles, and this allows us to breathe, to walk, or swallow as well. In people affected by myasthenia gravis, instead of creating helpful antibodies, the body creates harmful antibodies that block those signals that travel from the nerves to the muscles and reduces their contraction. And one of those harmful antibodies is the anti-AChR antibody. And this is where the term anti-AChR antibody positive myasthenia gravis originates from. And it also represents the majority of the generalized MG patient population. Next slide. So I mentioned generalized myasthenia gravis. However, there are 5 other types of MG, though generalized myasthenia gravis and ocular myasthenia gravis are 2 of the most common types of MG experienced globally. And I'm going to pass it on to my colleague Victoria, who will now walk us through the common symptoms and treatment options for MG.
Thank you so much, Zainab. So MG is known to be or called a snowflake disease, which means that people present in different ways. So this also means that people with MG experience a variety of symptoms that range in severity. Symptoms can present mainly in 2 different ways, one being with the eyes, and often we see people with droopy eyelids or blurred or double vision, and the second being through the muscles, where people experience difficulty swallowing, muscle weakness, and difficulty walking. Next slide, please. So there is no cure for MG, so therefore treatment options are aimed at achieving long-term remission and reducing the severity of MG to mild or minimal symptoms. Unlike the majority of neuromuscular disorders, MG does have treatment options that are Health Canada approved, as well as other medications that are off-label. And there are a number of treatment options already developed, like the ones that you see on the slide, as well as more in the pipeline. There are only some of the treatments that are available, these are only some of the treatments that are available and that our patients have undergone, and we will hear more about our participant experiences with these treatments from Homira later in the presentation.
Wonderful. Thank you, Zainab. Thank you, Victoria. So why is Muscular Dystrophy Canada looking at capturing the myasthenia gravis experience in Canada? Well, MG is one of the conditions that falls under the umbrella of disorders at MDC. And what we have heard through our interactions and experiences working with people with MG over the years is that there are some challenges clinically, there's some challenges in accessing treatments and reimbursements for treatments. And they really align closely with the challenges of other rare neuromuscular conditions as well. You know, in terms of rare diseases, sometimes there can be some challenges with high cost drugs or high use of healthcare resources. So we thought, why don't we pause and hear directly and work directly with the MG community in Canada to learn about the journey right from the time of the first bothersome symptom or sign of MG. We thought we should capture a 360 view of MG. We should really look at not just the clinical experience in terms of how it presents, or the time to diagnosis, or what that diagnostic experience is, or who is involved, but also the attitudes and the feelings and the emotions that comes with every single step in that journey. Also information. At MDC, we have something called the research hotline, and we have our service specialists in almost every province who can help to support with providing resources information. What are the questions that people with MG ask along their journey? And so in order to answer some of those questions, we had to take a multifaceted approach in how we collect this information. First off, having one-to-one semi-structured interviews. For these interviews, there was a robust guide, an interview guide with questions included that was co-developed by our patient research partners who are on the line, Margot and Linda, who are here today. So really, when we did these interviews, we started off with one simple question: tell me your story, or start from the beginning. And through that question, many of the questions in the guide were helped to be addressed. We also held roundtables. So roundtables are small sessions on a platform like Zoom, like we are on right now, where people use photo voicing. They selected a photo, whether they had it themselves, they took it themselves, or they found online, to creatively represent their journey with MG. And I'm really excited to share some of those images with you later today. We also invited people with MG to participate in surveys related to health-related quality of life. This is typically how the MG journey or experience is captured clinically. And so we wanted to see, how do our results and the ways when you ask questions through interviews and roundtables fare against more common standard patient-reported measures. We also wanted to ask, what are the costs related to living with MG? So what does that look like in terms of time away from work, having to rely on caregivers, accessing a scooter or a walker, you know, getting a cooling vest? What are the costs? What are the costs for treatments, accessing healthcare, seeking a second opinion? What are the costs related to living with MG? Once we conducted the interviews and the roundtables, we really realized that there are 5 main phases or parts to the MG journey. I really want to highlight here that no two people experience MG in the same way. However, what we did through a method called thematic analysis, heard the different perspectives and looked at what emerged, what were more common experiences for each of these phases: symptom onset, pre-diagnosis, diagnosis, treatment, post-diagnosis. I just want to familiarize you to what you're going to be seeing in the next few slides. In the next few slides, for each of the phases that I just mentioned, I'll share with you what are some sub-phases, what are some ways in terms of how people experience this phase and who are they connected with, who are their touch points, what are some major needs or pressure points or pain points in the experience. How are people feeling during this phase? What are the questions they're asking? And we also opted to add whether during that phase, what would be the best Picker 8 principle. For those who aren't familiar, a Picker 8 principle, these are best practices for person-centered care. And you can see them along the bottom there: emotional support, empathy, equity, respect, fast access to reliable healthcare advice. That is a Picker principle. And so a person-centered approach puts people at the heart of health and social services, including care and support. And so we thought for every phase, we should see what would be the best practice, what would be the best way that clinical and community systems and partners can work with people with MG. Let's start right at the beginning: symptom onset. Typically, the phases that are nested within symptom onset is someone begins to experience symptoms. They're noticing that the symptoms are intensifying or becoming more bothersome, and then they reach out and seek support. Typically, when they're seeking support, they're first starting off with family members or with people in their social network who have a health and medical background, but then they tend to go to their general practitioner, their family doctor. As Victoria mentioned, symptoms in this project that were mentioned most commonly were related to the eyes, drooping of one or both eyelids, blurred or double vision, weakness of the eyes, feeling really eye fatigue, changes in facial expressions, having colleagues or family members point out that the way they smile looks different. Differences in vulvar function, how they swallow, the way they are experiencing more shortness of breath, impaired speech. Interestingly, when individuals were experiencing these initial symptoms, not only were they compensating for the symptoms, there was also this theme that emerged, which is rationalization. They were wondering, is this related to a stressful time at work? Or is this related to, I have a lot going on and I'm on a night shift? Trying to really relate it to stress. And that would be one way where they didn't necessarily want to go and seek formal supports yet. When they did look this their symptoms up online, usually the word MG, myasthenia gravis, did not appear. And oftentimes their search was really, is this serious enough? Is this a cold? Is this something that, do I really need to go and see my general practitioner? What really emerged as a pain point is during the symptom onset stage, there is very limited awareness around myasthenia gravis, but also it really seemed that seeking healthcare support can be deemed difficult. How do I make that appointment with my doctor? Do I now have to take time off from work? Will they see me? Though it seems challenging for many people to go ahead and make that next step, which is to reach out. And so again, from a Picker 8 principle, in this phase, best practice person-centered care would be there's clear information, communication, and support for self-care, and there should be fast access to reliable healthcare advice. Now let's go into the pre-diagnosis. This can actually look in 3 different ways. You can go into your doctor, first contact, they send you home. The symptoms worsen, you go back, they send you home, they send you for some tests, they make some referrals, they might put you on a treatment for another condition, and then you eventually see the right specialist and get a diagnosis. Or this can look different. In a different way. You could find that your symptoms are worsening, you went in, you were sent home, symptoms are worsening, and then you enter what's called a myasthenic crisis, where you might now be in the ER, in the ICU, ventilated, and in a position where you're not necessarily speaking for yourself about your healthcare experiences up so far. Or number 3, it could be incidental. People spoke to, I didn't have MG, nor did I have any symptoms, but I went in for a surgery or I took this drug, it interacted, and it was an incidental finding. They found out later on, they said, you must have MG given this interaction. In terms of touch points, people really did lean towards going to their general practitioner, but the ER, the emergency room staff and team were also frequent touch points. They were also referred to people like ear, nose, and throat physicians, psychotherapists, psychologists, psychiatrists, optometrists, dentists, dermatologists, all before a firm diagnosis. In terms of themes and actions, medical gaslighting was experienced from healthcare practitioners. People reported that many people told them it's in your head, and they often felt feeling dismissed. On average, in this project, we learned that people go to 7 different healthcare professionals on average and go to the hospital or clinic 9 times, typically ER, before receiving an MG diagnosis. And so that emotional journey is you're feeling desperate. You're also feeling dismissed. You're feeling exhausted. You're feeling like there's changes in your MG. So now you're doubting yourself as well. You're wondering, is this in my head? Why doesn't my doctor believe me? What could this diagnosis be? And again, not seeing MG come up. A pain point or pressure point. Those different physicians are not always necessarily talking to one another. There's a feeling of not knowing how to demonstrate the seriousness of your symptoms. You're also hearing about these other possible conditions. Malingering, is it chronic fatigue, Is it stroke? And being worked up for stroke is a common response that we heard here. People were also given diagnoses like ALS and Lyme, lupus. And so now you're managing looking up that information as well, and information about what life could be with those conditions. But now you get a diagnosis. And how do you get here? So if you went the route of you were referred and then went through seeing a number of different healthcare professionals or your main contact, now you eventually see a neuromuscular specialist, a neurologist, or a neuroocular specialist. They perform a clinical evaluation. They run a few tests and they confirm that you have MG. Or this could be done in a different way as well. You enter a crisis, you're in ICU. Typically, you have family members who are speaking on your behalf, sharing your symptoms and experiences to date. They run a clinical evaluation. They follow up with confirmatory testing later, but at that time, you receive a diagnosis. And so at this phase, the diagnosis of MG is typically missed or delayed. In Canada, through this project, we learned it takes, on average, 5 years to receive a diagnosis after the first bothersome symptom. Now, the range of that, of what we heard, is 0 to 22 years. 0 meaning that person who, had a surgery, had an incidental finding, or they were able to go into the ER, they got the right test, the right neurologist saw them, and they got a diagnosis. To 22 years, where someone's compensating, it's ebbing and flowing, it's changing, and then they eventually receive a diagnosis. Typically, participants reported on average 6 misdiagnoses. Can you imagine having to be told, I think you're malingering, I think you're faking it, I think it's in your head, I think it might be depression or anxiety related, I think it might be Bell's palsy, or no, it's chronic fatigue syndrome, you're a woman, you're working, you have children, that's the diagnosis. And so now you're reconciling all this previous information with this new diagnosis. At the time of diagnosis, the vast majority of participants in this project said, I wasn't told anything really about MG. Someone showed me a chart or said the word and kind of dismissed it as, oh, it's not as bad as you think. And someone said, you have MG, you're a lucky girl. And I thought, okay, great. What does that mean? Where are the resources, support groups? Nothing was mentioned. People also mentioned that they received a diagnosis in an academic setting, and they would overhear the neurologist speak to a team of residents or fellows about MG, saying, this is a rare case, you might not see this every day, and trying to overhear information that way. Or as soon as the neurologist left or the healthcare professional left, immediately picking up their phone, Googling myasthenia gravis. And so again, pain point, not enough information. Clearly a delay, a diagnostic odyssey, a delay in misdiagnoses, and using the healthcare system in a way that if it was an earlier diagnosis, it would be less use of healthcare resources as well. So now let's look at treatment. In the case of MG, as Victoria and Zainab pointed out, there are approved treatments for myasthenia gravis. While there are no cures, there are approved treatments, and there are also off-label use for managing MG symptoms. This is unique for neuromuscular disorders. There are not many neuromuscular disorders that have specific drugs available. With that said, what we heard from participants is that people have to make trade-offs between treatment efficacy and treatment burden. What that means is they really have to look at what are the side effects, how do I take this medication, what is the impact when making decisions around treatment. People also reported treatments take they're very slow to take effect. Sometimes physicians tell them, you got to wait a year before this takes effect, or several months. Someone said up to 36 months is what I was told. Be on this for 36 months and then we'll evaluate. And so people are really experiencing that there's still need for different treatments, and there's still need to have a voice in selecting treatment. Prednisone was mentioned as the treatment that almost everyone was put on immediately following a diagnosis, along with methadone was mentioned. But really, people who participated in the study talked about being on different treatments, to now being on a treatment where they quote unquote their physician and them do not want to rock the boat, as in it's working, they're not in a crisis, The symptoms are fully not gone, but they're also not in a very negative or poor position with the MG. So what are the pain points here? There is also inequitable access and availability to treatment. We heard some people say, I have access to Rituxan or rituximab. I live in this province. I do not have access to that. I'm able to get this in my home. Another province, I'm not able to get that type of support in my home and access that treatment in my home. People talked about if they didn't have quote unquote Cadillac, private insurance and drug plans, they wouldn't be able to afford some of these treatments. There was also this pain point that people heard about through forums and websites that there were other approved treatments in other countries, but they were out of reach and they were not available in Canada, or that the trial opportunities were not available in Canada for them to try these investigational drugs. What I'm not focusing in on today is there were a number of participants, a small number of participants who spoke about their treatment experiences with investigational drugs, with drugs under study, or going out of country to access drugs as well. So post-diagnosis. So now you have a diagnosis with MG, you've been placed on treatment or you've been changed with different treatments. So now you are being managed with a neurologist. People talked about once they have received the diagnosis, they often do want to seek a different opinion or tend to switch to a different neurologist. They are really mindful in their everyday experiences that there are good days and bad days. There's fluctuation. You know, your morning might start off in one way, but by the evening, you might be feeling another way. People are really leaning into informal caregiving help from family members. There's also there is this unpredictability, this issue of the unknown, not knowing a lot about MG and how it will progress and whether you'll have a flare-up or a crisis. Question, can I work? Can I care for my grandchildren? Can I travel? Would disability support apply to me? What does life with MG look like? How much exercise should I be engaging in? What types of foods should I be taking? Those are the types of questions people are asking. In terms of pain points, many people did speak about that they do not resonate with the identity of having a disability, which we'll speak about later on in this presentation. But they had to really work on creating new goals and redefining life goals, that they had to really come to terms with feeling like you don't want to push yourself too much, and still having to come to terms with the experiences that were traumatic in obtaining that diagnosis, or in the treatment experiences as well. And in this case, this is the phase where all of the Picker 8 principles should apply. This is where person-centered care and social support should apply. And so I'm really pleased to share that we took all of that information and we developed an awareness tool. Again, there is not a single MG journey, but this is a snapshot with a lot of words and visuals that helps to highlight that. You can see symptom onset can begin with eyes or changes in face, lack of awareness, going into the ER, frequent referrals, misdiagnoses. You can see on the diagnosis right here where the common misdiagnoses are listed. The types of MG are listed, the treatment, but then there's lack of communication. There's lack of conversation between the physician and the patient to say what treatments are best and treatments are taking to take effect. And then I do want to mention that through this project, never once in an interview or a roundtable did I get the sense from any of our participants of a poor me, not at all. And today's presentation and information should really help to highlight that people with MG are resilient and that they really are here to share their stories to improve the healthcare journey, and that they really are here to redefine their goals and live life on their best terms. We will be talking about the overarching themes, but before I do that, I did want to mention one thing, which is the MG journey that I just shared can look a little bit more unfavorable, can be worse based on these three things. Number one, intersectionality. If you're a person of color, of low income, women, if you live in a rural area, if you're of a different sexual orientation, individuals who talked about intersecting identities had poorer healthcare experiences with MG. Women particularly talked about more negative experiences in getting a diagnosis and being believed and getting access to treatments than men. People of color or different racialized backgrounds spoke about, for example, someone said, I'm Asian, I have an epicanthic fold, my eyes were not opening wide enough, and they said, well, based on this test, you don't have MG. So the standardized, the normative data for that test did not take into account how my eyes as an Asian woman. Advocacy. If you do not have the skills and resources to advocate for yourself, to ask for a second opinion, to ask for your clinical notes, to drive 6 hours to another clinic, to keep persisting and asking to see different healthcare professionals, that did make the healthcare experience worse. Number 3, if you have a rare form of MG, okay, so myasthenia gravis is rare, but if you have forms with no detectable MuSK antibodies, for example, that experience is even further delayed in receiving a diagnosis, treatment options are further limited, and that can make the MG journey more unfavorable. Here are some key themes that emerge from all of our conversation. Number 1, medical gaslighting. This is an informal term referring to how patients perceive their symptoms being dismissed or downplayed by professionals. As a person who was seronegative for years, not recognized as having MG, gaslighting myself, and also being gaslit by doctors who didn't recognize that I had myasthenia gravis. All the doctors were saying, it's in my head, 6 times. I was told it was in my head. And finally, we just got on a plane. We went to Vancouver and we walked into the general hospital. That quote also speaks to having the resources and the advocacy skills to being able to then move forward and receive a diagnosis. Self-doubt and withholding symptoms. There's a lack of confidence in the symptoms that are being experienced and withholding them from healthcare providers. This might be a product of, if you were dismissed earlier on in your journey, do you then withhold symptoms later on? I still suffer from self-doubt. I still wonder to myself, is this in my head? I withhold symptoms because I don't want my neurologist to think I'm lying. I mentioned something about itchy skin once, and they said it's not a symptom of MG. So people finding that they can't ask these questions or share these experiences with their physicians because of being dismissed. Cultural capital and social inequity of health. Cultural capital refers to social assets of a person: education, intellect, style of speech, style of dress, which can result in differences in health status. If I go dressed up, nice and smiling and as positive as possible, it's a very pleasant appointment. But if I go in and you're kind of like, I feel crappy, and you don't get a very good response from this particular neurologist. I don't know how to work within the system without just throwing personal money at it to get better treatment. Hidden and non-visible disabilities. I asked everyone who participated in this study, which I forgot to mention is over 104 Canadians to be exact. And the reason why, by the way, we stopped at 104 Canadians is we received saturation or achieved saturation. What that means is we could tell from the different stories that the themes were becoming the same. So we have heard from a number of individuals who talked about not finding that they resonated with having a disability. So what that means is when I asked them, do you have a disability? At first they said, no, I don't. But as soon as those words came out, they then said, I do, but I don't. As in, within a day, I can look like someone who has a disability, and sometimes I don't, or I don't qualify, this individual said, for disability tax benefit. And that pisses me off. The GP I had said, I can do the paperwork, but you won't get it because I can walk, I can see, I can feed myself. And they said it has to be a cumulative number of things. This other individual said, I park in a disability parking spot and I feel very guilty. And a lot of people spoke about this. They felt guilty for using disability related supports or services or spaces like this because they are walking into, in this case, a grocery store. But honestly, I could need to be carried out of the grocery store or have to use a walker or scooter to leave the store. My MG can flare up and I can look more disabled than I did minutes ago. The next theme was a snowball effect. Snowball effect in that a delay in receiving an MG diagnosis really results in a series of negative consequences later on. When people are not diagnosed earlier, it could impact education, job opportunities, socially, could impact you financially. The other snowball effect is having these crises without having a firm diagnosis can cause damage, and years and months of that damage, it's permanent. That's been done on your body, and it's hard to recover from that physically and psychologically. High use of healthcare resources. In 2020, MDC did a study called the economic impact of neuromuscular disorders, and MG was one of the conditions that we studied. And what we saw at that time was people with myasthenia gravis were high users of the healthcare system, as in they did report frequent visits to ER or ICU. And so while they weren't using necessarily certain assistive devices compared to other neuromuscular disorders, there was a high use of healthcare resources. And so people talked about being the frequent flyer of the ER or having to switch to a private physician because they needed to go in frequently, needed to be heard, needed to be attended to. And so that's why they made those decisions. There was a negative impact on work and social participation. People spoke about entering early retirement or never really working the same way ever again. I was able to go back to work, but I had to take breaks that normally I wouldn't have to take. And I'm not able to perform in the same way. Some days are unpredictable. Because of the side effects of the medications, I stay home a lot. People did speak about the COVID-19 pandemic was actually really helpful. Many people were staying home and it was common in terms of social participation online. But as people are now reemerging with in-person activities, there was this concept of being perceived to be antisocial. Informal caregiving. People with MG rely on informal caregivers such as spouses, close friends, partners, adult children. It's been extremely difficult for me to have to give up on independence and have to be so reliant in a way that I've never been in my life. Informal caregiving. Someone spoke about an experience where they rely on their partner for everything, and the person had a major surgery, and the next day they were helping them with getting medication instead of resting. Unpredictability and uncertainty of disease. Every day looks different for people with MG. Myasthenia gravis symptoms might be elevated on some days and might not be on others. That's the way my life is. It's learning how to live with that. And it's so unpredictable. I have some really, really good days, and then I'll have a couple of bad ones. It forces you to change. When I asked at the end of every interview and roundtable, what would you say to someone, another Canadian diagnosed today with myasthenia gravis, the vast majority spoke about advocacy. They recommended that a Canadian with MG who's experiencing symptoms should advocate for themselves, for better access to healthcare, for resources, for information. I asked for my hospital records. I drove hours for a second opinion. I never gave up on myself. If I didn't have MG, I wouldn't have been as present, as grounded. This is what I was speaking about. Many of these individuals talk about really being also grateful to the healthcare system, grateful to the fact that there are treatment options, but still needing to be fierce, needing to really be assertive in getting a diagnosis, being listened to, and having to advocate every step of the way and keep pushing through. So the information that I share, does this really match with the clinical questionnaires that are typically used in clinic or in clinical trials or research studies? You know, on your screen here, you're seeing 4 different examples of what are called health-related quality of life measures. They measure symptoms, health, discomfort, your ability to participate in activities. Some are specific to myasthenia gravis and some are general. They could be used with someone with any health condition. Interestingly, there was impact demonstrated through the results of these surveys, but sometimes they were underestimated compared to the stories and the experiences that were told. And so validated self-reported measures may not capture the full story, but what was interesting is through the journey mapping project where we did photo voicing, we were able to hear some more stories through these images. Right now, you are seeing a collage of different images that were submitted to us. And I want to go ahead and read some of the testimonials that are related. Let's go ahead and start with the pumpkin in the corner. I often feel like Cinderella, dashing to accomplish this or that before the antibodies turn the coach back into a pumpkin. Even with medication, the disease limits how many pages I can read, how many gestures I can make, and how many words I can speak. The aesthetic experience mimics a dreamlike state. The image next to it is actually one of a family, and it's that IVIG really surrounds everything they do, their family schedule, when they go on vacation, when they go to work, when they travel, they participate in activities. Another example is right at the bottom where for privacy reasons, I was part of the faces of those involved, but this individual shared, so I get emotional. This is my last photo where I was holding my son and carrying him before I got diagnosed. He was not even 3 years old. So I think the biggest thing that MG took away from me is my ability to carry my children. And I still grieve that 4 years later. I watch other moms carry their babies and it makes me sad because I wasn't able to do that for too long. You know, I was diagnosed 4 years ago and I too was turned away from my hospital here. We live in a small community. And as I mentioned earlier, this individual went to the hospital 6 times, unable to talk, unable to breathe. Half of my face wasn't working and I wasn't even swallowing properly. The last month, I was pureeing all my foods and just pouring them into my mouth and then pouring water, just hoping that it would all go through. All the doctors were saying it was in my head 7 times. I was told it was in my head. Finally, when we arrived at the general hospital, they told me, you have myasthenia gravis. I wish I could hold my children. I wish the damage wasn't done. On the next slide, you're also seeing some other images that were shared with us. A deflated Energizer bunny to reflect the feeling of fatigue throughout a day. And what I wanted to also share is this image on the side of the blue creature. This individual says, I selected this because she's dealing with a lot of things, this blue creature. She's confused, she's feeling crazy, she's feeling frustrated, unpredictable. She appears to be happy, but I think that's just a cover up. She's chilling on her butt when all she wants to do is get up and go. The stars above her head can depict the memory loss, the confusion. I find that when I'm talking, I can get stuck on a word. My thesaurus doesn't work. Her hairstyle is very simple. I found that I don't know if it's the medication, but I've been suffering with hair loss, and that's an issue on top of everything else. You're dealing with changes in your appearance. Her horns. I've been on prednisone for a year, and feeling of not being able to control my emotions. I can go from 0 to 100, and I go from being fine to I'm mad, I'm losing it, I have no control. It's like all is well, but the steroids are talking. It's road rage, her crazy eyes. I know a lot of people can probably relate to this. When I was first diagnosed a year ago, there were my initial symptoms that I went to. Now I am on treatments and things are getting better, but I still feel like this creature someday. I hope the smiling face is all that remains. So where are we at today? I have shared a lot of information with you, all really thanks to the people that trusted MDC to provide us with information. While collecting this information in a rigorous way, in a way that was rooted in research methods was important, the reason why we did this work is to action it out, to help to improve experiences, to help to shift public policy and really be change agents together with the FG community. So now we're sitting here today thinking, based on this information, how do we change the healthcare journey in Canada? You know, people reported that their physician said, I had only studied MG for 30 minutes in medical school. Can MDC help to support medical education on MG for ER physicians or family doctors? Can MDC really help to better understand the inequities in access for treatments and help to promote opportunities for other drugs or expanded criteria for treatments to become available in Canada? That's where we're at today. We're really brainstorming, working together to not only better understand this information collected, but working to change that experience. Why would you need to wait 5 years, 3 years, 22 years, 6 months to receive a diagnosis? Especially a diagnosis where there is disease modifying or life-changing therapies available. I'm now going to turn it over to Linda and Margot, who, as I mentioned at the beginning, are our patient research partners. Linda and Margot both have myasthenia gravis, and they have been instrumental partners in the Journey Mapping initiative. As I mentioned, they were with me from the very beginning in terms of designing the study, looking over the interview guide, helping to make sure Canadians with MG trusted MBC to get this information and making sure we really had good engagement. I wanted to turn it over to both of you to ask what you heard about today. Do the results resonate with you as someone with lived experience with MG? Margot, is it okay if I start with you first?
Hi, Humira, and everyone else. Humira, I'd like to thank you, first of all, for all the work you've done on this. It's incredible. And it certainly resonates. Everything that we've heard today in the support website, I've heard many, many times. I've heard many people saying, what do I do about this? How can I approach this? And I think the most important things that come out, and often one of the most difficult things, is to advocate. And you have to be able to advocate. And I mean, I worked in the healthcare field for 48 years, and I still have trouble advocating for myself when I go, but that's what you have to do. And you have to find out a way, or take someone with you who can also advocate, whether it's a best friend or your spouse or a parent, you know, or a brother or sister, something like that. The approach from the doctors is much different when you have someone else in the room, I found. And they're not as quick to say that's not related to MG, or if it's a person that, you know, will speak up for you, because when a doctor says that's not related to MG, you tend to sometimes just sort of withdraw and shut down. And that person can say, but you can't see her, you haven't seen her, or you haven't seen him when he's trying to get up out of the chair or trying to get up off the ground after he's fallen. You haven't seen the look of panic on their face when they're choking and they can't breathe. And this is related to MG, so you can't say that. And I think that's one of the most difficult aspects, is to know how to relate, or how to advocate for yourself and speak to these people who are very intimidating. They can be very intimidating because the whole experience is so overwhelming. And I just lost my train of thought there. Sorry. And you have to sort of try and overcome the self-doubt that this instills in you as well. It happens with so many people. It's happened with myself as well. I start thinking, well, is this related to MG or isn't it? Because so often they say, well, that's not related, it's not related. So, and just recently I went to my GP and I said, okay, before I tell him, you know, about the shortness of breath, and he says it's not related to MG, we need to rule out all the other aspects. And I have an incredible, you know, GP, general practitioner. And she said, okay, I'm going to send you to this person, and this is probably what will be done. And sure enough, that's what they did. And that person, that doctor, had gone and done his research on myasthenia, because he asked all the appropriate questions when I was in there. Like, I was just blown away by him, because he asked all the appropriate questions, you know, how does the medication work and all of this stuff. And I think that the advocacy and then the education are the most important aspect. Especially they need to somehow get education into the emergency departments about how to deal with myasthenia when they come in. When I was having pulmonary function tests done not too long ago, the respiratory therapist said to me, she goes, what's it like to have myasthenia? Like, she was very young and very inquisitive in that. And she said, we read about it in the books, but she said, we hardly ever see anybody with it. She said, what's it like? So I thought, okay, here's my chance. So I just sort of embraced it and educated her. She goes, I never would have guessed that. If someone came in when I was working in emergency, she said, I wouldn't have known what to do for them. So I think the two critical things sort of coming out of this, like I said, were advocacy and education.
Wonderful. Thank you, Margot. Linda, how about you? Hearing the results today and as you've participated in the project, what are your thoughts on what we've learned about the MG journey in Canada?
It's very thorough, and you guys have done a lot of work, and like Margot, I want to thank you for that. And like with me, I was diagnosed before the internet. So a lot of times when I went to Emerge, I had doctors and nurses that said, "Oh, what's that?" I'm lucky. I never had anybody doubt me, so I have that advantage. But we need a lot of advocacy with it, with doctors and marginalized people. I'm dealing with a Japanese lady who is trying to get treatment, and she's been gaslit and everything. And a lot of hospitals will not allow you to take a caregiver or an advocate in with you. So you're completely at the mercy of the doctors, and that needs to change.
And one thing that we've also heard is while there have been some suboptimal experiences with healthcare providers, to Linda's point, where she hasn't received any, anyone dismissing her, or to Margot's point, where there's an openness with healthcare professionals. I think this is where we also advocate and work together around fostering and instilling shared decision making. How do those conversations look like? Advocacy doesn't necessarily need to be, aggressive or where people are on either side. It could really be when you go into an appointment, there's a lot to cover. Maybe even preparing ahead of time, talking to your service specialist at MDC. I'm about to go into this neurologist appointment. I only go in once a year. I feel like I'm a candidate for another treatment. What would be some questions I can ask? And so really engaging in shared decision making. How can we really bolster that understanding and awareness of MG as well? So with that, I did want to share sort of where we're at, the progress. So based on today's information, we conducted those interviews, the roundtables, and the health-related quality of life survey. In progress right now is our FIND study. This is open to people with myasthenia gravis and their caregivers looking at costs. So if you'd like to participate in that study, please let me know. I'll also include it in after today's webinar in the email that will follow. I want to go ahead and thank you all for listening to our presentation today. Again, for the trust and people with MG having an MDC to conduct this work, for the time they gave. Some of these interviews were an hour long, sometimes an hour and a half, having these conversations and really knowing that this information will be used to influence change. MDC as a health charity, as an organization, really relies on the generosity of people like you, of people who are personally impacted by neuromuscular disorders, family members, supporters, donors, volunteers, Canadian firefighters, and specifically for this project, our grant sponsors, UCB, Arginex, Alexion, and Janssen, for again trusting us that we can do this work independently, together with the community, all to really influence change. On that note, while doing this project, we often heard from people that this was one of the first opportunities to engage in a project related to MG, and there are more opportunities coming about. I'm giving you two examples on your screen here that are part of the work of the industry sponsors that I just mentioned. I'd be happy to share the information with you by email, and if you're interested in participating, you can look online and learn more. I'll include the links for this as well. So with that, I'm going to go ahead and stop sharing my screen and open it up for the next 10 minutes if there are any questions you have for Linda, Margot, myself, Zainab, Victoria. You can put them in the chat, Q&A. We'd be open to answering any questions. So I'm seeing a question here. Margot and Linda, do you resonate with having a disability? Would you feel comfortable sharing that? Because people in the comment is sharing that they were surprised that people with MG do not identify with having a disability. Can you see why there is that disconnect?
I can definitely see it. It's hard realizing that you do have a disability, and it's hard if you're not older and gray hair and you have to park in a handicapped parking spot. No, not you, Margot. And you have people running up to your car saying to you, well, why are you taking that spot? You should save that for somebody who actually needs it. And I've heard that happen a lot to a lot of people, as well as it's happened to me. And then I get out of my car with my crutches and they're like, oh crap. So it's hard to wrap your head around, because you don't want other people to notice that you have a disability. So I can fully understand that.
I can agree with Linda there. It took me the longest time before I applied for a disability permit, and it took me an even longer time before I would use it. And sometimes I had a very difficult time getting back out to the car. I'd sort of get out and I'd have to stop and rest before I could even walk the rest of the way to the car. And but I finally accepted it, and I finally committed to, yes, I do have a disability, and I use my disability permit, and I park in disability spots. But it
Thank
took
you. Thank you, Margot and Linda. There are three questions in the chat, but two of them really highlight to limitations in the work that we've done. The first limitation, and I forgot to mention this, one is that we really spoke to adults with a confirmed diagnosis of myasthenia gravis. There are children affected by myasthenia gravis. When Zainab had that slide up around the different types or forms of MG, there's a juvenile form or a childlike form. We really are interested in better understanding the pediatric journey with MG, and that is one of the options that we're exploring as a next step. So that is something we have in mind. The other, the individual mentions here that they had suspected MG, no firm diagnosis, and they couldn't be part of the project. So there probably are a lot more folks needing support with their MG journey. And I think that would be a really unique or good next step too, is we know it takes a number of years and misdiagnoses. Could there be a campaign or an outreach to say, do you think you have MG? Or here's some symptoms. Are you checking off these boxes? Do you want to have a conversation with our service specialist or a research team member so we can connect you to a neuromuscular specialist or resources to better understand where you're at in the journey? Absolutely. A question here is, Linda, Margot, do you think society's stigmatization around disability contributed to hesitancy to identify the disability? So does the stigma related to disability also contribute to hesitancy? We know we heard that through the interviews and roundtables, that really the stigma did hold people back from identifying. What do you think, Margot?
Yes, definitely.
Yeah.
Yeah, definitely it does. It's one of the biggest problems is the stigma of what you think yourself as you're trying to adjust in your whole change that you have to, but also from other people that have no idea what myasthenia is, or any rare disease. Doesn't necessarily even have to be, you know. So
yeah. There's a question in the chat, or in the Q&A rather, whether comorbidities or having coexisting health conditions, whether that supports getting an earlier diagnosis, or does it increase the chance of misdiagnosis? According to our analysis, having a coexisting health condition or other health conditions actually delayed your diagnosis, because many times these are generalized symptoms, and so they're attributed to that other health condition. And so that's what we saw in our case. It actually, when I talked about those 3 ways that make the experience more unfavorable, we should probably add other health conditions. And so we'll make that change based on today. The next question is, how would you approach medical centers or clinics to inform and educate in a friendly and a tactful way? I know for another neuromuscular condition called Duchenne muscular dystrophy, we're doing what's called a DMD masterclass. We're really summarizing the standards of care, the best practice guidelines, information on MG, and they receive credit for it, healthcare professionals do. And I think that that is one way. If there was a Myasthenia Gravis masterclass, for example, that could be a really good way. The other piece is really summarizing research or information in a plain language, having it accessible, and then working together with your clinician on looking at that information and making decisions is another way to make some changes in those clinician-patient relationships. I'm seeing one last comment or question here. Extending my heartfelt thank you for the work MDC has done and the significant contributions Linda and Margot have made to the MG community. How would you can encourage patients to advocate for themselves, or what benefit could a physician or team help you to advocate? So I know Margot provided some examples in terms of bringing along a family member or a friend to appointments. We also spoke about, practicing or doing your research ahead of time, seeking support from a system navigator at MDC or on the research team to help prepare for those appointments. The other things that we should probably mention is advocacy is not an innate skill. It's not something we all know how to do. And so at MDC, we do have an advocacy toolkit. So if you want to write a letter or an email or kind of draft questions or work to access certain treatments, we can help you to go through that and come up with an individualized plan, because it really will depend on the situation. And then again, there's a few comments saying one of the best things MDC could do is to educate healthcare workers. This individual spent 8 weeks in the hospital, and much of the staff did not know what to do with MG. So on that note, I think what you can see is, while there has been some rich and robust information collected, which comes really naturally to you who have MG and you know it best, living with MG, now we're really in a position to take this information, action it out, and hopefully help to influence the healthcare journey with MG in Canada. So on that note, thank you all so much for your trust, your participation, your time today. Please do not hesitate to reach out to us, and we'd be happy to continue working on this and continue supporting all of you. Thank you so much. Have a great rest of your day.
Thank you, Mara. And
Thank you, Margot. Thank you, Linda. Thanks, Zainab.
Thank you, Humera. Thank you, guys.
Take care.